thanks Dr. Costa for inviting me to this meeting. Congratulations, and thanks to Dr. Asira for making this meeting possible. It's a great pleasure for me staying here and learning ideas with you. I was asked to give a presentation entitled Update on Intravitreal Anti-vegf Therapy. Now, sit back and think. Anti-vegf therapy, vegf is a growth factor. Have you known about growth factors 20 years ago from now? No. It's a story of modern medicine. It's a story of modern engineering, molecular engineering. So we have learned during the past 20 years, not by chance. We learned by scientific settings. And this is a treatment modality now available, which is giving us hope, I guess, for the future, for newer developments also. So when we think on anti-vegf therapy, we have to think on what is vegf doing, what is the growth factor doing. It has influences on proliferation, it increases cell proliferation. It has influences on vascular permeability. It has pro-inflammatory effects on the wound healing, on the hemodynamics. It's neuroprotective. It is important in the endothelial regeneration, and it is important for filtration and fenestration, and not only in the eye, also in the whole environment of the human body, in tumor growth as well. And we participate with the anti-vegf therapy on the developments and idea of tumor therapy. Here you see all the different substances already on the market. We have Macogen and Lucentis. They are approved for intravitreal use. And we have the Avastin, which is approved for intravenous use. And we will have new medications on the market in the near future, which is the vegf trap by Bayer. Now the few studies are underway. These are receptors which are injected into the vitreous cavity to capture, to trap the vegf molecule. And we have the siRNA treatments maybe in the future available, which stop gene expression intracellular for the production of vegf, or intracellular, let's say, post-receptor cascade. First of all, I like to give you some new data on the Lucentis trial. All of you are familiar with Lucentis. It's a Fab fragment, highly selective to vegf, highly affine to the vegf itself. It's a small molecule because it's an antibody fragment which easily penetrates the retina and therefore can reach the choroidal neovascular membranes. Lucentis has been approved in June 2006 in the US by the FDA and 1 year later by the EMEA in Europe for the treatment of neovascular age-related macular degeneration based on these trials shown here in summary, the Marina, especially the Marina and the Anchor trial. These trials were for 2 years with monthly intervals of injections of 0.3 or 0.5 milligrams of Lucentis. The Marina trial was for patients with minimally classic or occult lesions, and the Anchor trial for predominantly classic lesions. In the Marina trial, as you know, they had a control group with sham, and in the Anchor trial, they had a control group with photodynamic therapy. And you see here the results regarding preservation of visual acuity, which means not more than 50-letter loss of visual acuity. This were more than 90% of the patients in both groups of the normal therapy. And you see here the change of visual acuity. And this was very exciting when we got this information that a drug injected into the vitreous cavity can improve the sight, can improve visual acuity, and the patient feels that they can see better. Especially in the anchor group, the patient with the predominantly classic patients, there was a tremendous difference to the PDT group. And compare this to the normal course, you have here in between this area here, there is a 6-line difference, and comparing to natural course, which goes below, the curve would go below here, you have more than 9-letter, 10-letter difference, and this makes a true difference for the patient. However, other studies with not a monthly interval regime were not able to demonstrate the stabilization of visual acuity on this high level on the long run. Even the Sailor study, which was done for safety reasons, was not able to show this effect. And I like to demonstrate you here the new data of the Horizon study. The anchor patients and the Marina patients, as well as patients from another trial called Focus, were extended in the trial which called Horizon. The reason for this was that when the first patient finished the approval trials, Lucentis was not available, and because of this effect of Lucentis, it was necessary by ethical reasons to give these patients a chance for this treatment. But what you see here is that after the 2 years of monthly injections, based on the investigator thought patients might benefit from this therapy approach, and injection administered on an as-needed basis, there is a loss of this improvement which could be achieved by the monthly injections. And this is present not only by different doses, it's also present by stratification of the initial CNV classification, as you see here, and as on the change on baseline visual acuity at 24 months in the initial trial. Only the non-responders in the initial trial had a stabilization or little improvement, but the high responders and the stabilizers, they lost after this new regime. And the same is shown here for initial study months 24. This is now equivalent, shown here that the high responders here they lose, only the non-responders could be stabilized in a very low visual acuity level. So in summary, we have learned by these studies that a monthly interval examination of patients at least is necessary to treat as early as possible, otherwise we will lose the increase of visual acuity by the upload series of 3 injections, which is obligated to all of our patients. Another issue of discussion is the safety issue, and it's not the ocular safety, it's the systemic safety. Here, the company performed a study called SAILOR, a systemic safety study, with 2 cohorts. One cohort with patients treated according to the functional and anatomical criteria, and cohort 2 treated by the physician discretion. More than 4,000 patients were included in the study, And see here, the number of patients treated was very low. So this is not comparable to the Marina and Anchor trial. And when you look for systemic problems, stroke was the major problem in these patients, and the main risk factor for stroke was a prior stroke in these patients. So be careful using this medication in patients which have already a stroke. The other problem by these medications is hypertension. Here we have an increase of the hypertension in a rate of 9 to 10%. Here 3% in cohort of investigations has been performed since then, so Avastin is broadly used, not only in the US and Europe, also here in the Arabic-speaking countries. And our clinic did a lot of, or spent a lot of energy in looking for the safety and efficacy data. In cell culture, we were able to demonstrate that this medication in the dosage we use for intravitreal use is safe. Also, in the isolated and diffuse bovine retina model with electrophysiological examination, we were able to demonstrate that in the dose we use for intravitreal use, there are no toxic effects. In the mouse model, we were able to demonstrate that there is no pathological changes to the retina available, and that the medication penetrates, that Avastin penetrates the retina, and the functional data showed very good responses with the electrophysiology. We also did examinations to the functionality, to efficacy of choroidal endothelial cells, and were able to demonstrate that Avastin could stop the permeability of choroidal endothelial cells in the chamber model. We did examinations with the primate retina to demonstrate that Avastin penetrates the retina. This was in doubt for several months, and we were also able to demonstrate that Avastin in choroidal endothelial cells reduces the amount of fenestrations temporarily. And all of this is a lot of data which is convincing us that in cases where we do not have safety studies and clinical studies of approved medications, that Avastin could serve as an alternative for patients, especially for patients not treated for age-related macular degeneration. I'd like to show you at the final end of my talk this photograph of a diabetic case. It's before and after Avastin injection. And please note that this occurred during a few days after the injection. It looked like a fibrosis of this neovascular complex. This goes very rapidly. What is the reason for this? I guess by vegf and TGF-beta, we have a balanced situation. By removing vegf, we have an over-effect of TGF-beta, which is a proliferating, which is a wound-healing factor, growth factor. And this is the reason why this scarring, fibrosing process starts in eyes with diabetes, and maybe this is also the end point of treatment of patients with age-related macular degeneration. As you see here, before and after multiple injections of Avastin, you see a fibrotic scar underneath the fovea, and this is the goal we like to reach in the treatment of our patients. I have shown you the data of Lucentis, the updated data of Lucentis, and some ideas based on the Avastin treatment. Avastin will never be approved for intravitreal use in the future. However, especially in Britain, there are some studies underway to get more controlled information on this data. We summarized in a little booklet in German our ideas and our treatment experience, and it was my colleague Dr. Ziemsen, with whom I made this little compendium of intravitreal pharmacotherapy. Thank you for your attention.